We're going to back up a few steps here in the lung cancer process and go all the way back to screening and talk a little bit about the data from the National Lung Screening Trial and sort of where we're headed going forward. I clearly didn't learn what you just told me, Corey, forward. I went all the way to the end. How did I do that? There we go. There we go. All right. Here's the National Lung Screening Trial, published in 2011. Let's look at it very briefly. Do I have a mouse? Does this work as a mouse? No. That's okay. No, we'll work without a mouse. So this is in the words of our president-elect, a huge trial. All right, 54,000 patients almost, randomized over, in fact, under 2 years to either annual low-dose CT or annual chest X-ray. That was for 3 years, and then there was 6 years of follow-up. The follow-up was completed in 2010. And what we saw were two sort of main findings. One is that the incidence of lung cancer was a little bit higher in low-dose CT. Oh, I have a mouse now. Look at that. The incidence of cancer was a little bit higher in low-dose CT compared to chest X-ray. Not surprising. We always believe that a more sensitive test is going to lead to more diagnoses. Whether this actually reflects overdiagnosis of cancer, the finding of lung cancer that would never kill you is a little bit unclear at this point because we haven't followed these people all the way out to see if they ultimately die of their lung cancer or die of something else. That is an ongoing focus of the National Lung Screening Trial and sort of extended follow-up. What we saw in terms of the stage distribution was quite interesting, right? So ultimately for lung cancer screening to work to reduce overall survival, or to improve overall survival, and to reduce mortality from lung cancer is that you have to have earlier stage disease with low-dose CT. And what we see here is that that is in fact the case, that more stage 1 cancers are diagnosed with low-dose CT and less stage 4 disease, though in fact the distribution is perhaps not quite as impressive as one might expect if you were using such a highly sensitive test as low-dose CT is supposed to be. But this did reflect a change in lung cancer mortality. So these are the actual mortality numbers. And what you see here is that the lung cancer mortality in low-dose CT, my mouse went away again. The mortality is 247 per 100,000 person years with low-dose CT and 309 per 100,000 person years with chest X-ray. This reflected a 20% reduction in lung cancer-specific mortality with low-dose CT. The number needed to screen to save one person from a lung cancer death was 320. Pretty similar to what we know from mammography or from colon cancer screening. The all-cause mortality was also reduced by about 7%. Pretty similar to what we would expect based on the mortality effect of lung cancer in this very high-risk population. All right, I'm going to get this to work. I swear I'm pushing the right button. Guys, I'm having a little frozen button on going forward. Can I get a little help? There we go. The National Lung Screening Trial is, so we've got it back up now. There we go. The NLST is by far the biggest lung cancer screening trial that's being conducted in the world. As you can see here from this little pie chart, it's sort of dwarfs all the other ongoing studies. In fact, some of these have now been reported, and I'll show a couple of data points here briefly. But the other big trial, the Nelson trial, which is a European trial, is still pending, and we would love to see that this really reflects the data we've seen in the NLST, that there is a reduction in lung cancer mortality, but that data probably won't be available until next year. So let's take a little deeper dive into the NLST data. One effect that's probably good to know about is this effect of the reduction in mortality by the quintile of risk. So this takes the National Lung Screening Trial population, which is a high-risk population, patients over 55 with a 30-pack year or greater tobacco history, and divides that up into 5 quintiles along the bottom of that graph there, quintile 1 to quintile 5. If you were in the highest quintile, you have a predicted risk of lung cancer of over 2% in 6 years. You are the older patient here. You're the 75-year-old who has a 100-pack year history. You're the one who's very likely to get lung cancer in that population. In fact, it is that patient, the highest risk patient, who benefits the most. The y-axis here is the mortality reduction from low-dose CT. The person who just got into the trial, the 55-year-old who just got in with a 30-pack year history, in fact, has a mortality benefit that is extremely marginal. As you can see, that curve almost approaches 0 down there. So the point here is that if we are going to choose who to screen, we want to choose our highest risk patients, because it's not clear that the marginal patient, the one who has a relatively low risk of developing cancer, 0.55% in a 6-year period, will actually benefit from getting an annual low-dose CT, even though that is what is currently approved. And we'll come back to this topic in just a moment. So here's a meta-analysis of the NLST, including three other trials that have also been published up to date. You'll notice that the other trials, actually the N is not on this, but what I will point out is that the other three trials on here, the Dante, the DLCST, which is a European trial, the Dante and the MIL trial were two Italian trials, were all much smaller than the NLST. These are all trials of either 5,000 patients or smaller compared to the 54,000 patient trial with the NLST. Two of the trials have a quote-unquote positive effect, have an odds ratio here of around 0.8. And two of the trials are quote-unquote negative or perhaps even harmful when you use low-dose CT because their odds ratios or relative risks are above 1. So there's a little bit of confusion here in the field about whether low-dose CT really is the true benefit that we propose it to be, given the effect we've seen from some of the smaller trials, which is why we are so anxious to see the results from the Nelson trial. However, in the United States at least, the USPSTF has gone forward with a grade B recommendation, which means that there is a relatively reasonable likelihood of benefit. It's not a grade A recommendation, though, that patients who are 55 to 80 who have a 30-pack year history and have quit smoking within 15 years will benefit from low-dose CT. You should, if you are going to begin screening a patient in this group, you should discontinue screening when they no longer become eligible, which is that if they are a former smoker of greater than 15 years, if they have health problems that they develop that will limit their life expectancy, or if they're unable to undergo curative lung surgery. Because remember that the treatments in the NLST were essentially all surgical resection. Then they should not undergo low-dose CT. If you have a patient who's got very diminished lung function, who cannot have lung surgery, but who would be eligible for SBRT perhaps, we don't know whether lung cancer screening is appropriate for that patient population because that patient has a relatively a poor life expectancy from their lung disease, and it's not clear that they should benefit from low-dose CT screening and treatment of their lung cancer with alternative approaches to lung surgery. So here's a summary slide of the NLST, the USPSTF, and Medicare. It's not quite clear here again that the trial was 55 to 74-year-olds. USPSTF increased their recommendation up to 80-year-olds. CMS cut the difference and said screen up to the age of 77. Again, the criteria around smoking remain consistent across all three groups. And again, I'll emphasize the issue about being asymptomatic and not having competing comorbidities so that would preclude having lung cancer surgery. So I've talked a little bit about the benefits of lung cancer screening here so far. I've showed you about the mortality benefit. Let's talk a little bit about the risks, because ultimately the ability to determine whether someone should undergo lung cancer screening or not is really predicated not just on the benefits, the potential mortality benefit, but also on what risks they may incur if they get lung cancer, if they undergo a low-dose CT. So what I'm showing here on this slide is three bar graphs. The one on the far left are the number of nodules detected across all of these ongoing randomized clinical trials, with the NLST being in yellow on the far left. As you can see, a small lung nodule will be detected on upwards of 25 to 30% of all scans, and that's defined as a nodule that's 4 millimeters or greater. We detect lots of nodules on CTs that we use. And the majority of these, at least in the NLST, it was 96%, will not be lung cancer. So you're going to create a fair amount of anxiety. Many of these patients with small lung nodules are going to undergo more surveillance scans. They may even undergo biopsies, which is the middle bar graph there, which shows that the number of patients who've undergo a surgical lung biopsy for benign disease in these trials. So these are high-end academic centers in these various trials around the country and around the world. In the NLST, 25% of patients who underwent a surgical lung biopsy to determine what the lung nodule was due to actually didn't have cancer to start with. It's as high as 40 or 50% in some of the European trials. So clearly the risk here is that we don't want to send, with all due respect to my surgical colleague, Dr. Pass, we don't want to send a patient to Harvey if the person doesn't have cancer. But sometimes you don't know. The nodule is suspicious, the patient is anxious, and surgery is the only way to make a diagnosis for a particular patient. And then the number of biopsies total. So the last bar graph, the one all the way on the right, is the total number of procedures being done, either surgical biopsy or bronchoscopy or transthoracic needle biopsy in the overall population. So 2.5% of every patient in the trial had to have some sort of biopsy in the NLST, as high as 4% in some of the studies shown here. So even though 4% doesn't sound like a lot when you were screening 10 million people a year in the United States, which is what we think is the eligible population, that's a lot of surgeries, biopsies, bronchoscopies, needle biopsies, which in many cases may be for benign disease. So that, I think, summarizes the risks and ultimately why the USPSTF came forward with a grade B recommendation. It's unclear whether, when we institute this into practice, whether the benefits that we're seeing in the NLST will translate out to practice. Will the surgical mortality rate of 1 or 2% seen in the NLST be the same surgical mortality rate we see in patients who are outside of the NLST? Will we limit ourselves to 2.5% biopsy rate, or will biopsies in the community practices inch up to 3, 4, 5, or higher? The more invasive procedures we do, the more risks we will create, the more harms we will do, and the mortality benefit is unlikely to, of course, get better. So we'll increase the risks in practice, the benefits will stay the same, and that mortality benefit will start to merge down to zero. And so that is, of course, the concern as we institute and implement lung cancer screening across the United States. A few practical sort of considerations, shared decision making. So I think it's clear that in a grade B recommendation where the benefit is considered to be present, but certainly not absolute, that you should discuss the issue of whether a patient wishes to undergo lung cancer screening or not. The benefit, actually, let me go back and just say one thing about the benefit. I presented this as a 20% mortality reduction, which is, in fact, the case. I'm actually going to back all the way up to the slide here for just 1 second, because I think it's worth a point to be made. The 20% mortality benefit right here is only incurred by the patients diagnosed with lung cancer. This is a 54,000 patient trial. Of the 54,000 patients, about 2,000 went on to develop lung cancer. 52,000 did not develop lung cancer. So the mortality difference can only be measured in the 2,000 patients who had lung cancer. Well, if you think about the mortality benefit overall across the entire study population, the risk of dying from lung cancer in the entire study population, the low-dose CT arm, was 1.3%. The risk of dying from lung cancer in the chest X-ray arm, the control arm, was 1.7%. So in fact, from an absolute mortality benefit perspective, the advantage here of getting a low-dose CT versus not is 0.4%. Right? It's relatively small. Even in a very high-risk population, you are unlikely to die of lung cancer. You have an under 2% chance of dying of lung cancer over a 7-year period. So if we don't do it right, if we don't minimize the harms, then we may get this wrong and people will actually be harmed as opposed to benefited from using low-dose CT. All right. So I was here. Shared decision making. So this is where shared decision making comes in, right? We need to be able to reflect that concept of a small mortality benefit, but with the unknown benefit, unknown potential for risks and harms to a patient. So Medicare has taken this forward. This is the first time, as far as I'm aware of, that they are allowing physicians and practitioners to bill for a shared decision-making visit. You should, in fact, are required to perform a visit with a patient where you determine their eligibility, do shared decision-making using one of several available tools. That is, describe to them what the benefits are, describe to them what the risks are, try and make them understand how to value judgment those for themselves, and make a decision of whether to go forward with having a low-dose CT or not. Similarly, or at the same time, you should also provide them smoking cessation treatment if they're current smokers, and only then should you go forward with actually doing the low-dose CT. So there are some very nice resources. In the interest of time, I won't walk you through these, but the one I like the best, if you are interested in playing with it, is this one called shouldiScreen.com, developed by the University of Michigan. It is really just a terrific, terrific website. It walks you through sort of how to think about the risks, how to think about the benefits at an individual patient level. It's something you can use in the office for if you're ever discussing this with the patient, and it really, really is a nice tool. It probably takes about 5 or 10 minutes to do, which is why we can bill for it. I will tell you, though, that in the world of medical billing, you only make about $30 or $40 for doing the SDM visit with the patient. There is another paper-based tool from the American Thoracic Society, which is also nice and available on their website. So let's just talk. We've talked a little bit about this idea of the benefit from lung cancer screening being very small or potentially very small. And so one question that comes up is there a way to better select patients for lung cancer screening than what we are able to do currently? Right now, all we can do is say, hey, are you 55 or older? Have you smoked more than do you have more than a 30-pack year history, and did you quit within 15 years? Relatively crude measures in the current modern era of medicine, right? So let's talk about a risk prediction model. This is a risk prediction model developed by investigators in Canada using a different screening study. But what they did was, instead of just smoking pack years and age, they put a bunch of variables into a model, including age, race, and you can sort of read them all here: education, BMI, the presence or absence of COPD, family history of lung cancer, a variety of measures of their smoking history, and spit out a prediction model. So with this model, if you can identify patients, you can essentially identify patients who have a risk of developing lung cancer in the upcoming 6 to 7 year period based on how this trial was run. And what they've been able to show, and I'll walk you through this if I can with the mouse. Oh, it was working just a second ago. Oh, there it is. I'll walk you through this. So this is the NLST criteria. This is just age and smoking history. This is that complicated PLCO model, which I just showed you, which has those 7 or 8 variables. The takeaway point here is that for a fixed population, so I'm going to fix this population at 37,000 patients. If you just use age and smoking history of 30 pack years, you identify 482 true cancers out of a total of 678 cancers in this population. But if you use this risk prediction model, you increase your detection rate up to 563 cancers. It looks pretty small when it's looked at as a percentage of the entire population, but you can detect 25% more cancers using this little model than you can with just age and smoking history alone. So that's a big benefit, right? The one other big criticism of the NLST is that using 55 to 74 and a 30-pack year tobacco history only identifies 50% of the lung cancers diagnosed in the United States. But if we can use a model to detect 75% of the lung cancer in the United States, wouldn't we want to do that? Wouldn't we want to find the other 25%? Wouldn't the benefit versus risk sort of pendulum switch if we can identify more patients with cancer who are then potentially more likely to die? That's probably the case. But how do we put this into practice? So it's not clear whether clinicians are willing to sit in their office and crunch through a risk prediction model to identify who should or should not have lung cancer screening. Some clinicians use the Gail model, for example, to identify people who just screen for breast cancer. There's some controversy, though, around whether this could be implemented widely into practice, but it's conceivable, and at least been mentioned, that the USPSTF may switch their recommendation for lung cancer screening to a risk-based model the next go-around, which will probably be in a couple of years after the Nelson trial comes out. I just want to say a couple quick words at the end here about tobacco cessation. Certainly for our active smokers, approximately 40% of patients who undergo lung cancer screening in the trial and in the country for right now are active smokers. This is an ideal opportunity to think about smoking cessation. We think that the moment that a patient thinks about undergoing cancer screening is this moment where they are prospective and thinking about their health in general, and it's an opportunity then, sort of the teachable moment concept, that you can use that moment where they're considering their health and wanting to improve their health to provide smoking cessation therapy. It's unclear, though, of exactly how to do this and what effect the actual low-dose CT process has on whether a patient quits smoking or not. So let me show you some very quick data from sort of the 3 big trials that we know about, the 3 biggest screening trials from around the world. The European trials, interestingly, just by getting screening, they had a quit rate of about 11 or 13%. In the NLST, actually 25% of the active smokers went on to quit somewhere along the way during their participation in the trial. This is with no treatment. This is without getting the patch or varenicline or anything. They quit all on their own. So this is a motivated group. They're ready to quit. If you look at the data so this is the quit data shown graphically, and what these curves are is the finding on the low-dose CT. So you were a little bit less likely to quit if you had a normal CAT scan, but you still quit a fair amount in the NLST. But you were more likely to quit smoking if you had a quote-unquote suspicious nodule. That kind of makes sense, right? If I told a patient, hey, I got something that we're worried about on your scan, this could be cancer, you can imagine that their motivation increases and they're then more likely to quit. Again, this data is all without any pharmacotherapy. So for those of you who take care of these kind of patients, my recommendation is to make sure that at that moment where they're considering low-dose CT screening, you also refer them to a tobacco cessation program or do it yourself. Prescribe them pharmacotherapy. We're likely to be able to shift that curve really downwards and get people to quit smoking at the time that they are getting their low-dose CT scan. And I've sort of the same sort of data here, just sort of shown in a table format, that the more suspicious you're finding on the low-dose CT, the more likely someone is motivated to quit and does quit in this trial. And with 5 seconds to go, I will end and take any questions. I guess we're not doing questions until the panel, but we're doing it right now. Okay. Thank you for your attention.